All right. Good morning, everyone. Um, Welcome to our fourth presentation of the week of the first Antibiotic Awareness Week lecture series. We're happy you could join us today. We're going to have a presentation by Dr. Leila Abu Ispa, who is a clinical pharmacist at the Drug Information Center here at National Guard Riyadh. She is also the chair of the ADR committee and has been involved in many activities relating to management of formulary, and also she has a master's in infectious diseases, so she's very interested and involved in a lot of antibiotic related issues. Dr. Leila is going to talk to us today about antibiotic allergies, and this is a topic that's really important for safety purposes and for efficacy of medications. So, Dr. Leila, thank you for joining us. The floor is yours.
Okay, hi, Dr. Anur, and thank you for introducing me. So I hope that my voice is clear this early morning. If it's not clear, please write a comment in the comment box just so I know. But I told them I'll try to be as loud as possible. So I'm happy to be joining you today in this series of webinars, which is intended to help you save the world and spare our antibiotics. So starting off, I'm just going to say that I'm not a dermatologist and I'm not an immunologist. And as pharmacists, we're not really diagnosticians, but we are expert when it comes to drugs and their associated harm. So my talk today will focus on the immunological and the cutaneous, the skin, harmful effects associated with antibiotic use. Now you might be thinking, what does antibiotic allergies have to do with antimicrobial stewardship, and how knowing more about this will help this cause? So I'm hoping that through my talk today, I make that point clear, why we really need to know more about this and how it can help the efforts we do in antimicrobial stewardship. So objectives. So what I'll try to cover today is first, so I really enjoy understanding pathophysiology of how drugs can cause harm. So I'd like to spend some of the time reviewing the classification of drug hypersensitivity reactions based on the mechanistic criteria. So I'm apologizing in advance for the first couple of slides. They do seem to be a bit intense, but I promise it will get easier as we move on. But I think really it's important to have that basic understanding, and just knowing that classification will help you understand the importance of documenting patient antibiotic allergies accurately. I'm also going to share some stats on the adverse impact labeling patients as allergic to antibiotics may have. And finally, I'll share some of the knowledge we have developed over the past decades regarding cross-allergy and how to reach to a clinical decision on whether to use a drug or not. So as time allows or permits, I'll go through the penicillin and the sulfa cross-allergy topic. So the penicillin cross-allergy with cephalosporins and the sulfa allergy. Okay, so starting with a definition, so a drug hypersensitivity can be defined as any reaction to a drug that involves your immune system or inflammatory cells stimulation directly by a drug. So under this definition, it includes true allergies, to say those that involve your immune system. It also includes exaggerated pharmacological effect that in some ways stimulate inflammatory cells, and the pseudo-allergic reactions. And I'll talk about each one of these types in details. For classification, so there are a couple of different classifications of drug hypersensitivity reactions, but really the Gell and Coombs classification is by far the most popular, and it's commonly used. It's almost 60 years old. The classification was developed by these two British scientists who together really set the base of our understanding of immunology. And just a fun fact, so if I don't know if you recognize the Coombs. So Coombs is the scientist who invented the anti-RHA antibody test. So he is a fun fact is that he's actually a veterinarian who later on went into the field of immunology research. So there are other classifications that are used, like there's another one called Kirkpatrick classification, where basically they classify hypersensitivity based on the timing of onset of symptoms into delayed and immediate. But really, the Jelen-Coombs is much more detailed and explains the pathophysiology behind the reactions. So they divide hypersensitivity reactions into 4 types. And I'll talk about each type in details in the coming slides. So, but most medications tend to cause just one of these types, but some drugs like penicillin, for example, can induce any one of these 4 types. Okay, so starting with type 1. So type 1 hypersensitivity reaction, it starts off with the patient's first exposure to the drug. So he tolerates it and he's totally fine, but under that time, his immune system is actually undergoing a very kind of sophisticated recognition of the drug. So his beta lymphocytes start maturing into plasma cells and start producing what we call drug-specific IgE antibodies. So if you look at this figure here, those green Y-shaped parts, so those are IgE that are now very specific to that drug. And these IgE antibodies then go attach themselves to the Fc receptors, so these little tiny pink stuff, and on the mast cells and basophils throughout the body. So at this point, you can say that the patient is sensitized, meaning his body has the ability to recognize the drug as soon as it comes in again. So let's say in a later encounter, the patient is exposed to the drug again. The drug will now bind to those IgE antibodies. So imagine this orange dot is your drug, so which in this case is an antigen now. It can bind to those IgE antibodies. And then something happens, so called cross-linking. So you have that cross-linking between these antibodies, and that cross-linking causes an immediate degranulation of the mast cell. So these now activated mast cells start releasing all these chemical mediators, so mainly histamine, serotonin, and then within 30 minutes you have other stuff like leukotrienes. Leukotrienes are way much stronger than histamine. They can lead to the symptoms of bronchospasm. You have also the release of prostaglandins that lead to increase in secretion and the edema signs and symptoms. And then you have many other mast cell associated cytokines like TNF, interleukins. All these are released and result in the classical symptoms, which we call IgE mediated drug reactions. So common clinical features of this reaction is the articardial rashes. As you can see in this figure, which I have a bigger figure of that, yeah. So these are associated with itching, flushing within seconds. Now, if you're giving the drug IV, the immediate reaction can happen within seconds of giving it. It can be slightly delayed to minutes if you're giving a drug orally. So when we say urticaria, its typical appearance is as you see in this figure. So you have these well-defined raised erythematous plaques of different sizes. The patient can also start describing difficulty in breathing, a weird sensation in the throat. Some might also vomit or feel extremely nauseated, and then the more severe the cascade, it can result in hypotension and potentially a full-blown anaphylaxis event with even cardiovascular collapse. So all of these symptoms typically occur within minutes to an hour of administering the offending drug. And of course, if all of these symptoms are not early recognized, it can be a life-threatening situation. So key features of an IgE-mediated reaction is that immediate onset of those symptoms. So an IgE-mediated reaction does not begin several days into a continuous course of therapy. That's just not possible. Really the big problem is when the only symptom you have documented about your patient's allergy is rash. with it can be very difficult to differentiate it from other types of rashes. I will talk about the different types later, but especially when you only have the patient's word describing the rash, or a very old documented allergy in the system with no description, so you don't really have a clear picture. And I'll talk about the different skin manifestations in the coming slides and how to differentiate them. But this is what a typical urticarial rash of an IG type 1 hypersensitivity reaction looks like. So antibiotics that commonly cause a type 1 reaction are penicillins and cephalosporins and quinolones. The concept of cross-reactivity, which we'll talk about more later, is but it arises basically from the similarities in the chemical structure between certain drugs. So they can also bind to those Y-shaped IgE antibodies because of that similarity in the structure, and then cause a similar reaction. So a cool thing I wanted to share with you when I was preparing for these slides is that I found this microscopic view of a resting normal mast cell, and the other one is an activated one. So that's a degranulating mast cell releasing all its chemical mediators. So it kind of looks like a bad hair day. I thought this was a pretty cool picture to share. Okay. So the most severe form of an IgE-mediated reaction is anaphylaxis, and as per the National Institute of Allergy and Infectious Disease, a diagnosis of anaphylaxis can be made if the patient meets any one of these three criteria, so these three boxes here. So in the first box, if your patient, let's say, for example, had any immediate onset, so at the top, all of them have to have an immediate onset. So if the patient had immediate onset of, let's say, a cutaneous symptom, so flushing or hives, and one of the symptoms in the orange box, so respiratory, like bronchospasm, or one of the symptoms in the blue box, like hypotension, so a drop in blood pressure, then it is likely that this was an anaphylaxis event. In the second box, if the patient meets two of these four colored boxes in these groups, for example, let's say he had hypoxemia with an immediate vomiting or cramping, then this is likely also to be an anaphylaxis event. And I always remember Will Smith when I talk about anaphylaxis in this movie. So anyway, in the third box, if your patient only develops a significant drop in blood pressure within minutes to hours of an exposure to a drug, and then that alone can indicate that this was an anaphylaxis event. So if you don't have any other clear reason for that drop in blood pressure, it's likely that it was an anaphylaxis event. So it's important to know that anaphylaxis is an emergency situation where if you don't act fast, a patient can die on you as a result mainly of asphyxia and the blockage in the airway or a cardiovascular collapse. So time is of essence, and identifying these symptoms early on is crucial to save the patient. So you need to act quickly. So we know we have these anaphylaxis kits ready, so you need to use them, administer that EpiPen as soon as possible, and activate code blue if needed. So there's also a possibility of a biphasic reaction to occur, so patients can rebound, and in that case, we observe so all patients that had an anaphylaxis event for at least a minimum of 8 hours after that event. So as anaphylaxis can be terrifying, the good thing is that they are rare. So in a study we did at our hospital, we collected all antimicrobial related anaphylaxis cases. And we found over a period of 4 years, only 42 cases of anaphylaxis related to antimicrobials. So directly to an antibiotic. There was not a single mortality case directly related to anaphylaxis during the study, so no one actually died of an anaphylaxis during the study period. But we did look at some of the adverse outcomes related to antibiotic selection after the event of anaphylaxis, and how that was linked to first a longer hospital stay and also infection-related mortality, mainly due to poor choices after the anaphylaxis event. This study is still under the painful process of peer review. I'm sure many of you know how painful that process can be. But I do hope it's going to be published soon and that we can share our experience with others. So moving on to type 2 hypersensitivity reaction. So this type is also called cytotoxic hypersensitivity because it involves antibody destruction of healthy cells. So there are several mechanisms under this group, but I'll talk about one of them. I'll talk about this one in the first part of the figure. So one example is when you have penicillin and it binds to the surface of a red blood cell. So imagine this drug is a penicillin and it binds itself to the surface of a red blood cell. And then that causes a recognition of these red blood cells as different. So the beta cell proliferation takes place and drug-specific IgG in this case, so not IgE, IgG antibodies to the drug are produced. So you have these IgG that bind to the penicillin on the surface, and this complex, so this drug IgG complex activate the complement system or phagocytosis, and then these mediators of inflammation are generated at the site, causing cell lysis and death, and which in this case you will have something called drug-induced hemolytic anemia. Other adverse effects that fall under this type are drug-induced immune-mediated thrombocytopenia, commonly seen with sulfonamide and vancomycin. Not commonly, sorry, can be associated with the use of sulfonamide and vancomycin. Also drug-induced neutropenia, which is seen with antimalarial drug amodiquine. And so for hemolytic anemia, drugs that have been implicated in that kind of reaction are cephalosporins and penicillins. Okay, moving on to type 3. So type 3 is pretty much the same as type 2. I didn't mention, but both type 2 and 3 are very rare reactions, so it's not something that you would see on a daily basis. So in type 3, the difference is that the drug which is acting as an antigen here is freely floating and not attached to any cell surface like we saw with the penicillin and on the red blood cell. So imagine this is your drug, and so you also have IgG formed that bind to these soluble drugs and forms an immune complex. And these immune complexes will deposit in the blood vessel walls. So wherever these immune complexes end up in or deposit, they activate the complement system there, and macrophages and neutrophils are attracted to the site, and where they can cause inflammation and lead to tissue injury. So these complexes are commonly deposited in areas like the joints, where you can have drug-induced arthritis, or in the kidney, where it's causing nephritis, or in the blood vessels causing vasculitis. So onset of both type 2 and 3 reactions are delayed. So type 3 is within 1 or 2 or more weeks of exposure to the drug. Now the last type, so type 4 reaction, which are not really mediated by antibodies. Instead, type 4 reactions require memory T cells. Memory T cells that are specific for the drug to occur. So upon exposure to the drug, the immune system, the immune response is mediated by these specific subtypes of T cells that really orchestrate an inflammatory response through the secretion of cytokines and recruitment of all the other effector cells. It often appears after weeks of exposure, and then suddenly your patient develops signs and symptoms of a severe immune reaction. So this results from that uncontrolled expansion of oligoclonal T cells that have been massively stimulated by the drug. T cell mediated delayed type drug hypersensitivity reactions range from mild rashes to life-threatening severe cutaneous adverse reactions like Stevens-Johnson and DRESS and 10, which we'll talk about. But according to the pathomechanism on the T cell, this type is further subdivided into 4 groups, as you can see in this figure. All reactions involve T cells really have prominent, like very significant skin findings, because the skin really stores a massive number of T cells. So you almost have always significant skin manifestations in type 4. So I'm going to warn you before I move to the next slide that I do have a couple of pictures that are a bit painful to even watch and look at. So if you prefer not to see these photos early morning, now's the term to now it's time to turn around. The severe forms of type 4 cell-mediated reactions can be further grouped into what we call SCAR, severe cutaneous adverse reactions. They include acute generalized exanthematous pustulosis, also known as AGEP. It's severe, and this is the photo, so it is a severe reaction. Its onset is typically within 4 days of drug exposure. It's characterized by this acute onset of mainly these numerous tiny pustules that are on a red base. Usually this type is not life-threatening or anything, but it does look severe. Spontaneous resolution is seen within 2 weeks of this reaction, this type of reaction. And then we have the second one, which is drug reaction with eosinophilia and systemic symptoms, DRESS. Its onset is within 2 to 8 weeks of exposure. So all these reactions are delayed hypersensitivity reactions. Mortality is around 10% in DRESS. It looks like it kind of looks like a maculopapular rash, but here you have no edema. The significant finding is in this reaction is also that you have those systemic symptoms. So you have fever, eosinophilia, lymphadenopathy, and always some kind of organ involvement. So the patient can have, for example, sudden liver function test abnormalities. And then the next one is the two really scary ones, which is Stevens-Johnson and toxic epidermal necrolysis or necrolysis, however you want to pronounce it. Basically, 10 is the same as Stevens-Johnson, just you have a wider body surface area affected, so more than 30%. In these severe cutaneous reactions, you always have blisters. The blisters are very loose and easy to rub off. Often with a gentle touch or a pull, you have these skin sheets falling off. So the affected area is extremely painful. The patient feels very ill and has chills and fever. Some of the patients might even drop their hair and nails. You have sores that appear on the mucous membrane lining of the mouth, throat, and eyes. So even cornea can become scarred. Mortality is pretty high and can reach up to 40% in toxic epidermal necrolysis. These patients are painfully treated in the burn center, like a burn patient, and or at least in the ICU, and treated with immunosuppressants. So really, when we say drug allergies, the first thing that comes to our minds is really those skin manifestations. So a skin reaction. So other symptoms might not always be obvious or present in mild reactions. So characterization of these skin reactions is very important. And we know we can't possibly, of course, consult dermatology and immunology for every skin rash a patient develops. So really just a general awareness of these different types I think is important for everyone. So nurses, pharmacists, and other physicians that are not in the field of dermatology or immunology. So if we want to look at the skin-related symptoms alone, if you have a patient with only skin-related symptoms and you want to figure out what type of reaction it is, we can categorize them in one of these 3 categories. So for the IgE-mediated skin reactions, like we said before, they have to have happened immediately on exposure to the drug. So you have that immediate onset. The rashes are raised off the skin. They're pretty itchy. They fade fast. They don't leave any scars, so there's no scarring. And a good way to recognize this type is that if you press on them, they turn white. Not that I've personally done that, but that's what I've read. So there's typically no mucus involvement or any organ involvement in type 1 IgE-mediated reactions. Then we have benign T lymphocyte mediated reactions where onset is delayed, so typically within days of exposure. Typically, they're less itchy than your IgE mediated reactions. Lesions may last longer, and you might have very fine, simple desquamation, but it resolves also spontaneously or with topical treatment in days to weeks. This type does include also what we call the maculopapular rashes. And then, of course, we have the severe ones, like we talked about, the Stevens-Johnson dress and toxic epidermal necrolysis. Onset is delayed, so days to weeks. You have profound blistering, mucosal involvement, and almost always some degree of organ involvement. So I hope really that this kind of clarifies a little the difference between the skin rashes of these different types of reactions. Okay, so to make everything more confusing, we have something called pseudo-allergies, so which makes really the whole problem with allergies a bit difficult to differentiate. So pseudo-allergies are also called anaphylactoid reactions. They are characterized by an immediate onset of symptoms, so similar to the IgE, immediate onset, but that are very similar. So the symptoms are very similar also to the IgE-mediated symptoms, but the mechanism involves an immediate release of the mediators, like the histamines from the basal cells and the mast cells, but that's not triggered by any IgE. So you don't have IgE antibody recognition of the drug. So it's a direct effect on the mast cells that leads to the release of these histamine and other mediators. So there is a proposed mechanism for this type. So there's actually a couple. So one of them is that there are specific receptors on mast cells called MRGPRX2. And these receptors can recognize certain chemical structures of some drugs. And there are some well-known examples of this type, so pseudo-allergic reactions, and I'll talk about some of them. So one of the most famous types of pseudo-allergic reaction is the red man syndrome with vancomycin. It occurs in 50% of patients. And so red man syndrome is not IgE mediated, and it usually related to the rapid infusion of vancomycin. It causes direct activation of a mast cell and that histamine release. So we usually manage it with slowing down the infusion. So if it's over 60 minutes, you can even go longer if the patient develops the red man syndrome. Another example is with fluoroquinolones, which are known to bind to those receptors I talked about, so the MRGPRX2, causing some skin manifestations that can be immediate in onset and look like an IgE-mediated reaction. Finally, the common reaction we see also with abelacet, ambisome, where these liposomal forms activate directly the complement system. And symptoms are usually handled, of course, with pre-medication, and usually patient tolerates it with a pre-medication. Okay, so that was the most technical part of the presentation. So moving on to some lighter information. So now that we have really covered the different types of hypersensitivity reactions, which I really hope you're able to contemplate, I'll just go now through some of the clinical consequences of labeling patients allergic to antibiotics, especially when they're truly not allergic. So the first consequence of a drug allergy label is that you narrow your therapeutic options. So, which in many cases might be your first line or even the most effective choice. So if you think about penicillin, cephalosporins, and carbapenem alone, they make up 30% of all the current antibiotics we have. So imagine removing 30% of these perfectly good choices off the table. For example, imagine using vancomycin for MSSA, where neftacillin and cefazolin are actually more effective than vancomycin in treating MSSA, or not being able to give benzathine penicillin to a patient with syphilis or ceftriaxone for gonorrhea. So there are many situations where the alternatives are less effective than your first choice, and that's one of the main clinical consequences of labeling patients allergic. Another concerning setting where labeling an allergy can have some bad consequences is in the surgical prophylaxis setting, where we know, for example, cephalosporin is your first choice for many types of surgery. And in this study by 2018 by Blumenthal and colleagues, they found a 50% increase in surgical site infections in patients labeled with penicillin allergy. So a significant increase in surgical site infection for patients that are labeled allergic. So, and that's after they controlled for surgery type, demographics, and procedure duration. So, pretty significant. And Macy and colleagues in 2014 did a case control study, and they compare patients labeled with penicillin allergy and matched them to those who had no allergy label. And what they found was that patients labeled with a penicillin allergy were more likely to receive fluoroquinolones, vancomycin, and clindamycin compared to the control group, and more likely to receive a third generation cephalosporin when a cephalosporin was indicated. And in the top 10 antibiotics used in patients labeled allergic, 5 of them were those associated with C. diff. So ciprofloxacin, clindamycin, ceftriaxone, moxifloxacin were more used in patients labeled allergic. So really, labeling patients allergic to penicillin can also increase the risk of resistant infections. And this large cohort study, again by Blumenthal, by the way, he's in one of these hospitals in Boston, and he has numerous studies in this field. So if you are interested in this area, I recommend that you read his studies. They're pretty interesting. So in this study, they included 64,000 patients labeled as allergic to penicillin. And over a 6-year follow-up, those who were labeled allergic had almost a double risk of MRSA and C. diff compared to the control group. So pretty significant. And of course, so for many antibiotic alternatives, you have a higher risk with many medications or other alternative antibiotics, a higher risk of adverse effects that are not immune mediated, like nephrotoxicity, for example, vancomycin. So usually your second best choice are more toxic drugs. And besides the clinical consequences, there are definitely financial ones too. So, which can be a main driver for your institution if you want to increase awareness about this problem and implement policies in your hospital through antimicrobial stewardship. So, if you tell them that there's money associated with it, it usually makes things move faster. In this systematic review of literature, they report that an incremental cost related to patients being labeled allergic to penicillin can reach up to $600 per patient. That was in the inpatient setting. They also did analysis of the outpatient setting. But approximately $600 extra for being labeled allergic to penicillin. So one common problem we see in practice is you have an allergy documentation for your patient in his electronic health record, but with no details at all on what the symptoms were or the nature of his reaction was. And if you're lucky enough to have the symptoms, you might not have details about the onset, which we all know now is important to know what type of reaction the patient has, so how you can classify it. And something else that we commonly see is that documentations don't really specify which drug, so and may be labeled as allergic to a whole class like this one, so penicillins or cephalosporins, instead of documenting exactly which cephalosporin, which you'll see later is important in the decision-making process when deciding on alternatives. Another important missing information in allergy documentation is documenting what the patient actually tolerated, which can really be a lifesaver sometimes. So when you can't really ask the patient or get good history of his allergy in an emergency situation, having that documented that he tolerated this cephalosporin or tolerated amoxicillin can really be very helpful. So whenever you see a patient's allergy labeled with no details, maybe find some time to interview the patient and update his allergy with all the details as much as possible. You can also ask your clinical pharmacist to assist with this. I'm sure they would be happy to do something like that. And this goes for nurses too. So I will now focus on penicillin allergy, which is really the most commonly reported drug allergy or antibiotic allergy. So in this study in the UK, out of 100 million patients exposed to oral amoxicillin over a period of 40 years, there was only one death after an anaphylaxis that was identified. So really, mortality from an IgE-mediated drug reaction is very unlikely, especially in a hospital setting, just because we're that immediate onset. Healthcare providers are pretty aware of those symptoms and know how to deal with it. Really, death, and due to the rarity of this of anaphylaxis, really mortality is not too reported to be that high, like I showed you in our study too. So just some quick facts. So I tried to look up some Saudi data, but I really didn't find much in this topic, which is something maybe we should work on. But anyway, in the USA, they report that 32 million people have a documented penicillin allergy. And 95% of those ultimately tolerate the penicillin and were not truly allergic in the first place. And like we said before, so true IgE-mediated reactions and anaphylaxis are pretty rare. So most patients labeled as allergic never get a full evaluation of their allergy. Skin rashes, can appear for many other reasons. So it's not only the drug. Viral infections can also cause skin rashes. So maybe the patient had a viral infection and happened to take an antibiotic at the same time, and then you don't know, was it the viral infection or the antibiotic that caused the rash? So in many situations, that's the case. Another fun fact is that with years, a person can actually lose their sensitivity to penicillin. So they lose those IgE antibodies. Very funny. So 50% will lose them in 5 years, and 80% will lose them in 10 years. Okay, so as I mentioned before, penicillins have been reported to cause all 4 types of these hypersensitivity reactions, where IgE-mediated reactions are kind of rare. Type 2 and 3 are extremely rare, and the most commonly reported penicillin hypersensitivity reaction is the delayed benign rashes, likely a type 4 hypersensitivity reaction, most commonly a mild maculopapular rash. And most often the reactions will not reoccur, and there's my maculopapular. Okay, so most often the reactions will not reoccur, and patients even can receive the penicillin with no problem. So that's your typical maculopapular rash. So delayed onset, mild, no mucosal involvement. Most of these patients can tolerate penicillin again. So there are multiple decision algorithms out there, but I really like this one that's from Johns Hopkins. I'm not going to go through the whole algorithm, don't worry, but I want to focus on the situations where you can consider delabeling a patient's allergy. So the first would be this one. So if your patient had actually some features of an IgE reaction, so some of the features here, but not really a full anaphylaxis. But then after that had a negative skin test. So he did a penicillin skin test and it was negative. So the negative predictive value of a penicillin skin test is pretty high, so up to 97%. So it's a pretty reliable test. So if we're looking at immediate reactions. So if a patient had that negative skin test, or after documenting these symptoms happened to have been challenged with the penicillin and tolerated it, then you should go ahead and remove that allergy label, which is a suitable action, I think, in this case. The next one is if a patient reports only isolated GI symptoms, like he only vomited, or reports only had diarrhea or dizziness, with no other symptoms. In this case, again, comfortably delabel that patient's allergy as it's likely just an intolerance and can definitely be given a penicillin again. The third is when a patient himself reports taking an amoxicillin augmentin with no reactions. So he reports that whatever's documented in the system is incorrect and that he always takes penicillin and has no problems, then also you should consider taking that information out. Of course, if you are 100% sure that his word is reliable and you can rely on his history or his information that he's giving. And the last is, okay, so if the allergy is more than 10 years old and the patient has taken a cephalosporin with no reaction, so in this case, you don't really remove the penicillin allergy information, but at least document that it's more than 10 years old, and also document what cephalosporin the patient tolerated, which can be very helpful. So this is their algorithm that they use. We can follow some of them. We don't have to necessarily follow everything that they recommend here, but it's pretty easy to go through this algorithm in your decision-making process. So remember, basically any patient with scar, anyone who reports blistering rashes, anyone with organ involvement, all these should be evaluated by a dermatologist or immunologist if suspected to be drug-induced. And of course, re-challenging is contraindicated. Even a skin test should not be done in these kind of patients. So patients reporting these reactions should not even receive a penicillin skin test. So in a recent publication in JAMA, they share a very nice collection of toolkits that can be used to document a patient's penicillin allergic history. And basically, they put patients into one of these three groups, so low risk, moderate risk, and high risk. These toolkits were developed jointly, so by IDSA and American Academy of Allergy. They're pretty cool toolkits, so I do recommend that you go in and have a look at this paper. So after documenting the symptoms using those toolkits, and it's not, and the symptoms are inconsistent with scar, hemolytic anemia, or any organ involvement, then the patients can be stratified into these, so low, moderate, and high risk, and they make recommended action for each type. And I'll break it down in the coming slides. So for example, in the low risk group, if you have a patient that only reports GI symptoms like the John Hopkins algorithm, or a family history of penicillin allergy, or itching with no rash, so ornithuritis, or a 10-year-old history of a mild reaction with no features of anaphylaxis, then their recommendation is that you can go ahead and prescribe a penicillin. Or if you're a bit worried about you're unclear on the symptoms, then you can do a direct challenge. So the direct challenge is simply giving half of a dose, like 250 milligrams of amoxicillin, and just monitoring and observing the patient for 30 minutes or an hour for any immediate reactions. And then in the moderate risk group are those who only have urticaria or pruritic rash, and those with some features of IgE-mediated reaction, but like, for example, swelling, but not really fulfilling a full-blown anaphylaxis event. And of course, as I said, we're excluding from all these algorithms those with blisters or any mucosal or organ involvement. So in this group, a skin test is recommended in this paper, and if positive, you should avoid, of course, penicillins and document the result in patient's medical record. And if negative, you can go ahead and do a graded challenge, which is what I described in the previous slide. And those that are high risk, so like those that had an anaphylaxis event, then if the drug is still needed, so you don't have alternatives available, then you could also refer them to allergy immunology to do a desensitization, which is also possible if the patient reports IgE type mediated reaction. Desensitization is a possible solution in this case if you have no alternatives. So another big issue with the patients labeled allergic to penicillin is the issue of cross-reactivity with cephalosporin. So We all get those pop-up messages when you have a patient that's allergic to penicillin and you would try to prescribe a cephalosporin. So the early studies of cephalosporin allergy report a very high cross-reactivity rate with penicillin, and some of the reports up to 40%. So all these drug labels for cephalosporins early on had contraindications of using cephalosporin in a patient with penicillin allergy. However, these studies were said to be flawed because for two reasons. So first, crude cephalosporin preparations were contaminated early on. So during the production of cephalosporin in those days, they were usually contaminated with penicillin, and that resulted in overestimating the true incidence of cross-reactivity. And the other reason is just the flaw of reporting these in case reports. So these patients have an underlying already higher risk of hypersensitivity reactions, so it might not necessarily be a true cross-reactivity. So more recent studies report that cross-reactivity is much lower, as low as 0.1% between penicillins and cephalosporin. So overall, cephalosporins are less allergenic than penicillins, and it was previously thought that cross-allergy between penicillin and cephalosporins were related to the beta-lactam ring, which was later on we found out that no, it's related to the similarities in the R side chain. So in these are side chains instead. So. And these R side chains are different between certain cephalosporins and different between different penicillins. So in patients with a penicillin allergy or a cephalosporin allergy, you should aim for a cephalosporin with a dissimilar, so a different R side chain. So now for the opposite situation where a patient, for example, is labeled allergic to a cephalosporin, but not to a penicillin, and symptoms are suggestive to be an IgE mediated, then a penicillin test can be done in this case. So you can go ahead and do a penicillin test. The opposite, so doing a cephalosporin tests are less reliable, and we don't commonly do that because their predictive value is not that high. But if you don't have skin test available, then you can still consider in this case a graded challenge based on the symptoms of the patient if they're not that severe. Other drugs we know don't cross-react is aztreonam. So it does have, however, it does have a similar R side chain to ceftazidime. So if a patient is allergic to aztreonam, you shouldn't be giving ceftazidime because of that similarity. Carbapenems are also very low risk for cross-allergy, and monobactams are typically fine. So this is from our most updated APP in the National Guard, where we added an appendix that shows those cephalosporins that share similar side chains. So here I have, let's take one example. So for example, if you have a patient that is allergic to cifdroxil, you will avoid cephalaxin, yeah, this one. So cephalaxin is because of that, the similarity in the R1 side chain. So, but you would be totally fine giving a third or a fourth generation, or even some of the second generation cephalosporins in this case. So cross-reactivity appears to be high, the highest for beta-lactams that share an identical R1 side chain, and to a lesser extent the R2 side chain. So that's why you'll find those that share R1 will be in red, and those that share similarities in the R2 side chain in orange. Finally, and super fast, I'm just gonna say about the sulfa allergies some points. So again, they rarely cause IgE mediated reactions. The most common type of reactions with sulfa are type 4. HIV patients seem to be at higher risk. There is no evidence to support cross-allergy between sulfa antibiotics and sulfa non-antibiotics. So to say, if you want to give your patient Lasix, which has a sulfa moiety, and he has an allergy to Bactrim, you can go ahead and do that. There is no evidence to support that there's cross-allergy between these two groups. A common question I get is, can I give morphine sulfate to a patient with a documented sulfa allergy? Yes, of course you can. So since it doesn't contain that sulfa moiety we are so worried about, which is very distinct and very different than sulfates and the sulfur. So you can definitely give morphine sulfate. We also have a policy for the sulfa allergy and an algorithm at National Guard that you can have a look at. Finally, just going to share with you that the IDSA stewardship guidelines do recommend doing antibiotic allergy assessment, including penicillin skin testing and ensuring accurate allergy documentations for your patient as an important part of your stewardship program. These are my key messages. So please always question drug allergies, especially when it's antibiotics. Ensure proper documentation of onset of symptoms, the types and features of rashes, other symptoms that might have happened, how long that reaction occurs, so the date of its occurrence, and then so you have two dates: the date of occurrence and how fast the onset was after being exposed to the drug. And also, if you can add the tolerated antibiotics to the patient documentation under his allergies, that would be very useful. So penicillin allergy labels can drastically alter the clinical outcomes like we saw and lead to less optimal care. And I can take some questions now.
All right. Thank you, Dr. Leila. That was
wow, that's 50 minutes exactly.
Yes, really good timing. We have some time for questions, so please
Okay,
answer. For the audience here, please ask us all your questions so we can ask Dr. Leila. So I have a few here. First, I mean, going back to type 1 hypersensitivity, there are two questions that are kind of related. Would you say that the type 1 hypersensitivity happens at the first exposure or at subsequent exposures? And the following question would be, does that mean that the patient will develop an anaphylactic shock even if, at the first exposure or second exposure? Yeah.
So it's very interesting. So to really say it was an anaphylaxis, a type 1 hypersensitivity reaction, you have to have had a previous exposure. So and that's the difference between anaphylaxis and anaphylactoid. So in order for the patient to develop these sophisticated IgE drug-specific antibodies, you need that previous exposure. But it's something that can happen and has been reported is that which is where you are exposed to something that is similar to the drug, and you can develop IgE that is specific to that drug before you're exposed to it because of the similarity of something else that you were exposed to. I hope that's clear, but
it is.
So it can happen, but it's rarely that. So in most cases, you have to have had a previous exposure to the drug to build these IgE that are specific to the drug. And if you haven't, or you're completely sure that there was no exposure, then it's likely that it was an anaphylactoid reaction.
So basically, let's say we have a patient now on one of the wards. The nurse administers one of the medications. This seems to have been the first time the patient receives this medication, and they develop a hypersensitivity reaction that looks like a type 1 hypersensitivity reaction. And then the questions would have to be, have you received this medication before? Have you received any other antibiotics before that you've tolerated maybe more than once? What other questions would you ask the patient?
Yeah, so I definitely get that a lot too, that question about, or some people tell me, how is he allergic when he tolerated it last week? So that's how the immune system works. I mean, it suddenly recognizes the drug as something harmful and starts attacking. Definitely, if you tolerate an antibiotic, it doesn't mean that you cannot suddenly one day become allergic to it. So that's how it works. So yes, I mean, documenting that when he was exposed to it, onset of symptoms is extremely important. So we'd want to know how fast the skin rashes or any other symptoms appeared, because that can really help you classify the reaction, what they tolerated, and then how specific the rash is. So just writing the word the patient had a rash, that's definitely not specific, and that is really not really helpful in next encounter. So like in months to come or a year after that, if you have documented rash as mild, that doesn't tell you much. I mean, you're just going to have to avoid the drug because you're not sure what happened. So something we're working at in the National Guard is really actually, it's actually been approved by the Best Care team, which is our electronic healthcare record, or our electronic healthcare system that we use. We asked them to build in a feature where we can take pictures of patients' allergic rashes, and so we can use those as a part of the history. So it will show up under the allergy of the patient. So under alerts, where you have documented the patient's allergy, you can actually take a photo of that rash, because most of these rashes will resolve very quickly, so in a week, and if no one actually sees them and characterizes them, then you lose the opportunity of figuring out what kind of rash it was. So that's something we're working on, and hopefully it's in production. So it's been approved, and it's with the production team. So I think that would definitely add value to understand, what type of reaction the patient had.
Absolutely, yeah. That makes sense. I think you've answered that question thoroughly. The other question is, I know you've mentioned repetitively that we all have to document what the allergy looks like, or what information we know from the patient, when they received the medication, how long it took from the administration to the onset of the first symptoms that were, the patient communicated to us. So this is everybody's responsibility. So this includes everyone involved, so physicians, nurses, and pharmacists.
Yes.
Or anyone else for that matter.
Yeah, if you don't mind, can I interrupt you on that?
Yes, please.
Yes, so it's very important, because I think it's hard to say one person is responsible, so only the physician or the MRP, because we really want that person who witnessed the reaction to describe it. So I think nurses, as a frontline during administration, can pick up these type 1 hypersensitivity reactions and the symptoms. So I think they probably are the best to document that, but it's definitely everyone else. So the physician can probably put in the more details about the skin rash. Clinical pharmacist can help identifying the different drugs that were administered. Yeah, so figuring out which one. So we know most of the patients are not on one drug, so you have probably a patient with 6 or 7 drugs, and the clinical pharmacist can probably help identifying which one was the culprit based on the onset and when he received it. So it's really a multidisciplinary team, and that needs to add value to documenting the allergy, and it's definitely not one person or one profession that's involved in this.
Absolutely. Great. So everyone's involved, that's clear. But then whose responsibility is it to label the patient as allergic or delabel the patient?
So for now, in our healthcare system, access is only for physicians. In my opinion, it is a diagnosis. So when you say a patient has an allergic reaction, or had an allergic reaction, or had anaphylaxis, it is a diagnosis. So I do believe it is a main role that physicians should take in documenting that or flagging them in the system. However, nurses do that too, and probably follow up on that. So and our ADR team also, any reported ADRs that involve an allergic reaction, we immediately go in and check and see that the patient is flagged. If he's not flagged for his allergy, we contact the MRP and we discuss why he thinks we shouldn't, and we come to a consensus on whether to flag the patient or not. So we have a very in place system to follow up on patients' flagging and documentation of allergies. Yeah.
Nice. And I know you mentioned it before, but you mentioned that if, let's say, a patient is documented to be allergic to medication, so let's say penicillin, but then they happen to tolerate cephalosporin multiple times, that it would be really important to document not in the medical record only, but also to add it to the labeling, right?
Yeah, so it's something we're going to work on too. So adding in that allergy box, I think I had a picture here on our best care allergy alert part. Yeah. So if we can add here tolerated, for example, something that's probably would be useful. So that's something I think we can work on to add. Yeah. So to add what patient tolerated, especially for antibiotics. Yeah.
Yeah, sounds good. All right, that would be great, a great addition. A last question here. Is Are skin tests effective in detecting antibiotic allergies for all antibiotics?
So not for all antibiotics, unfortunately. So for cephalosporins, they're not commonly done. Their sensitivity or specificity is very low, pretty not useful. But the penicillin skin test is pretty well established. So you need a couple of things to execute it. So you need the major and the minor determinants. You need a positive control, histamine, and a negative control, normal saline. And then you have different steps. So in that, actually in that paper I shared with you from JAMA, they have actually details about how to conduct a penicillin skin test. But unfortunately for cephalosporins, yeah, in this study. So if you go into that reference, you'll find details about the penicillin skin test and how to do it and how to interpret it. But yeah, for cephalosporins, it's not used. It's not that well validated as the penicillin skin test. For other antibiotics, again, it's not as well validated as the penicillin skin test.
Great. We have 10 more seconds for a last question. I think the answer can be, what's the best approved protocol for detecting allergy for cephalosporins and quinolones? I'm not quite sure what the question is trying to say, but can you comment about detecting allergies for cephalosporins and quinolones?
I'm not sure I got that question, but okay, so detecting, I don't think you need sophisticated tools to detect. I mean, they're pretty clear. I mean, drug reactions are like, most of them are immediate, or even if they're delayed, you can pretty tell that it was the drug that caused them in most situations. So you have that sudden skin eruptions, that skin manifestation, and with the immediate onset IgE type mediated reactions, you have the other symptoms happening within minutes. So I don't think you need more sophisticated tools to tell if it is, but there are also skin biopsies that can be done. So dermatology do order sometimes skin biopsies to try to figure out if this if there's severe cutaneous reactions. You can do a skin biopsy to see if it was likely. They're not that specific, but they can tell you that it's likely drug induced or not. I'm not sure if that answered the question that you were asking.
I think it does. And I
Okay.
also will just add that there are some algorithms, rather than the word protocol, perhaps they're asking for algorithms. And there are some algorithms published out there on, I just thought of that, yeah.
Yeah, so there are, if you just Google, you'll find a lot. And in our hospital, if you go into our formulary, we have under each antibiotic algorithms to help you in the cross-allergy issue. So if you have a cephalosporin, penicillin, sulfa, we have even for other drugs like NSAIDs and aspirin, cross-allergies. So we have multiple algorithms that you can link to through our formulary.
Absolutely. All right, wonderful. I think we're good out of time. So sorry for all the other questions that we weren't able to address. Please contact Dr. Leila or myself if you're within National Guard, or find a way to reach us.
Sure.
Thank you, Dr. Leila. That was really
Thank
thorough and
you.
interesting. Thank you to all the audience that has attended today, and I hope to see you at 12. Thank you.
Yeah. Thank you, everyone.
Hello, everyone. Good afternoon. Thank you for staying or joining us again. My name is Noor. I'm an infectious disease and antimicrobial stewardship clinical pharmacist, for those of you who don't know already. I am working here at the National Guard in Riyadh. I work with the team, the infectious diseases team, and pharmacy team, as well as the quality, patient safety, nurses, anyone who really is important to work with us in antimicrobial stewardship here at National Guard Riyadh. As you know, we've organized this Antibiotic Awareness Week. This is the 5th session, and the one before last. The last one is tomorrow morning at 9. So I'm gonna share my slides with you here. One second. All right, so I'm going to be talking during the session about antimicrobial stewardship at the dental setting or at dental services, which is a very under addressed issue. And I'm going to share with you the reasons for the importance of this discussion. So we're going to look at defining stewardship and antimicrobial stewardship programs, just briefly for those of you who didn't attend the beginning of previous sessions, understand the rationale for antimicrobial stewardship events and activities and programs in dental services, and discuss the elements and activities of ASP in dental services. So if this isn't clear to you yet, I hope this slide will make it clear one last time. Stewardship is defined as the careful and responsible management of something entrusted to one's care. So that means that whatever is given to you, you need to be responsible of it because there's a finite or limited amount of it for such as water, electricity, or whatever else is limited in resources. So this is why stewardship expands to stewardship of natural resources. And of course, we can also talk about stewardship of antimicrobials, which is the purpose of this week. In more or less, the importance of stewardship is in line with the fact that it's estimated that 700,000 people die of antibiotic-resistant infections a year. And by 2050, the cumulative global cost will be 300 trillion lives and between 60 and 100 trillion dollars. So I know everyone now is concerned about COVID, and we're all at home. We can't travel. We can't live our lives as we, were so blessed to have in the past. But we're still blessed because, COVID can be managed, and hopefully so can AMR. I'm going to share with you here an example of what could happen if antibiotics are used inappropriately. And this is a specific example talking about a patient whose name is Peggy Lillis in the US, who this is a website that was organized by her son. And this patient, Peggy, took clindamycin for a root canal, after a root canal for an abscess, for a duration of 6 days. And she developed community-acquired Clostridium difficile associated diarrhea, which is one of the pathogenic organisms that can cause really, really severe diarrhea. And she actually died. So this isn't, an urban legend of, right, take your, eat your broccoli and so you can grow up and be, this is an actual situation where a patient took just 3 days of clindamycin and she died because of C. diff. So this is why every dose, every patient matters. So if you think that, right, you started an antibiotic, should you continue? It doesn't matter that much. It actually does. This proves that to us. So no, we know that antibiotic stewardship is important for resistance. And we know that antibiotics are also, at some point, right, you could say, what if we can just buy a new antibiotic that was developed recently that can solve the problem? Well, this is also another situation where you could say, all right, I'm running out of options, because actually, as you deploy new antibiotics in the market, resistance is observed. So the bacteria and the bugs are smart in their own way, which is just basically survival. So they survive. In order to survive, they need to develop resistance. So we know that we don't have enough new antibiotics because it's expensive, and no one's interested in paying so much money to create new antibiotics that no one is going to buy because they're too expensive. So this is why the recommendations now are for governments and organizations to fund development of new antibiotics and vaccines. We spoke about our C. diff case, but what about antibiotics causing adverse drug events in children? This is also one of the leading problems of using antibiotics. It can it's actually is the main cause of adverse drug reactions in children, causing ER visits. Also, a really large proportion of antimicrobial prescribing in the outpatient setting is considered inappropriate, specifically pharyngitis, sinusitis, and bronchitis. So 1 of every 2 patients is receiving an antibiotic inappropriately. And this also extends to dental settings. We spoke about selecting for C. diff, and that's a big problem. And this is because of all of these concerns. Accreditation standards now require antimicrobial stewardship to be part of any hospital that requires that is interested in accreditation, and so does SABAHI, which is a requirement. And there are specific recommendations for antibiotic prophylaxis in the dental setting within SABAHI's recommendation. So the standard says that comprehensive assessment is performed for each patient to include the need for antibiotic prophylaxis. So that means, does the patient need it? Don't miss it. And if the patient doesn't need it, how can we make sure that they don't receive the antibiotic? So a goal of a stewardship program in general is to optimize clinical outcomes. So how can I make sure that my patient receives the best care possible? And in addition to reducing the unintended consequences of antimicrobial use. So you need to find a way to improve and measure the use of antimicrobials and improve the appropriateness. And I'm going to just go into details here. The whole stewardship program is based on the premise of ensuring appropriate selection of the antimicrobial based on the appropriate diagnosis, drug, dose, route, frequency, and duration. If you're able to ensure that these items are appropriate, then you have an optimal patient care plan for this antimicrobial. But the question is, how do you ensure that these items are appropriate for all patients at all time in facilities that have high turnover? And this is why stewardship programs are necessary. You need to identify where are your gaps and how do you improve them. And in turn, of course, there's a huge role to discuss about costs, reducing healthcare costs. So the patient, we mentioned Peggy, who developed C. diff, that was unnecessary. Not only are you causing harm and an unfortunate outcome, but also this person was in prime age. She was 56. She probably had a productive life with whatever her profession was. So this is an opportunity cost as well. So stewardship teams involve specialists in ID from the physician specialist and the clinical pharmacist specialist, microbiologist, epidemiologist, ISD or information system specialists, infection control practitioners, end users who include dentists and pharmacists and physicians of all specialties, nurses, and the quality teams. So you see here dentists have a big role because they are prescribing antibiotics. And if you want to ask us about how much antibiotics they're prescribing, and if dentists are stewards of antimicrobials, there's some data that suggests that up to, of all antibiotics prescribed in the community setting, 10% of them are prescribed by dentists. That's a very large number. And up to 80% of that prescribing is deemed inappropriate. So you could say that 8% of community antibiotics dispensed in the community are inappropriate, at least 8%, and this is due to dental prescribing in this example. This is a study that was conducted in 2016 in British Columbia, Canada, and if you see here, if you see follow my mouse, physicians and surgeons prescribe 87% of antibiotics, and dentists in this situation prescribe 11%. Pharmacists prescribe 0.38%, which is also surprising because generally pharmacists shouldn't prescribe, but I believe in this case there were some collaborative agreements or possibly inappropriate prescribing. Another study in 2014 in the United States also showed that dentists prescribe around 9% of all antibiotic prescribing of the total antibiotic prescription. So this is why addressing dental prescribing of antibiotics in dental setting is important. And who gets the most antibiotics in the dental setting? So it's from this graph. This is also the study conducted in 2016 in British Columbia. They saw that patients aged more than 40, hold on here, more than 40 receive most of the antibiotics, you can see, and the trend is increasing from 1996 to 2013. So these it seems that elderly patients are more likely to receive antibiotics. So this is important just to keep it in the back of our minds. Why are people considering giving antibiotics to those patients specifically? Then the next question would be, all right, what kind of antibiotics are they dispensing in the dental setting? This study here in 2017 shows that around 7 prescribed by dentists are penicillins. Lincosamides or clindamycin is around 4%. Macrolides are around 1.3, cephalosporins are around 1.2, but then you see some antibiotics that really shouldn't be prescribed in this situation, like you see here quinolones, 0.21%, so that's really unnecessary. Urinary anti-infective agents, 0.02, but even in that case, why is there any prescription in that situation for done by dentists? So there needs to be a bit more evaluation and audit in the dental setting, self-audit within the dental setting. So now that we've established that antimicrobial stewardship in general is also involves stewardship in the dental setting, we're going to just talk about some basics in prescribing and of antibiotics. So this is an important concept. Antimicrobial prophylaxis or antibiotic prophylaxis is when you use an antibiotic to prevent an infection. So the infection is not there yet, but you expect, due to the nature of the surgery, for example, that you require added support to prevent the infection. The other situation where you might use antibiotics in the treatment is the treatment of an infection. So you already have an established treatment that can not be managed through surgical care, for example. So in this case, you can either give the antibiotic empirically or before identifying the bacteria, which is the most common scenario in dental prescribing, or definitive, where you get a culture, you identify the bacteria, and then you prescribe. And this is more likely when you actually take a sample, when there's an abscess, when there's a long-standing infection. So it's important in your minds to decide, am I using this antibiotic for my patient, or is this physician using this antibiotic for the patient to prevent an infection or to treat a pre-existing infection? Because the recommendations, of course, differ. So one interesting study, it was a poster published in 2018 in ID Week, showed that they evaluated 3 dentistry clinics in Utah, in the US, and they saw that 6.1% of dental encounters were associated with an antibiotic prescription. 90% of the prescriptions were not associated with prophylaxis. So they saw here that really, for some reason, these dental clinics are using a lot of antibiotics to treat infections, where actually in a lot of data it shows that most dental infections do not require antibiotics, they require surgical intervention. This is another interesting study from in 2015 that looked 2019 actually. It assessed the appropriateness of antibiotic prescriptions for prophylaxis before dental procedures, and they saw that 90%. They looked at how many patients had gingival manipulation and how many patients had cardiac conditions, which are the 2 main criteria to decide if a patient requires prophylaxis or not. We're going to talk about this, but this study specifically looked at these 2 in order to see how many patients would actually be eligible to receive antibiotics. And what they found is that effectively 81% of antibiotic prophylaxis in dentistry in this situation was unnecessary. So this also echoes our concern. What are some of the themes identified or concerns that may allow us to understand why there is an increasing rate of antibiotic prescribing? And so this is a group of dentists that came together and put together some idea. They put on paper why they think a lot of their colleagues prescribe antibiotics sometimes inappropriately. So some of them suggested that treatment of periapical abscess may be a reason, and what should happen in this situation is definitive treatment as opposed to giving an antibiotic. Treatment of irreversible pulpitis, where also the treatment needs to be surgical and not with an antibiotic. Prophylaxis for third molar surgery. There's no special recommendation here, but it's not recommended. So you give an antibiotic in this case. Increase in prescription associated with dental implants and bone grafting. So there is a large growth of using dental implants, especially by general practitioners, where they may not use antibiotics in the best way possible. Perioperative prophylaxis in patients with prosthetic joints. And the guidelines don't recommend giving antibiotics in prosthetic joints, so practitioners still have this idea that they need to use antibiotics here. Perioperative prophylaxis for patients with valvular heart disease. There are clear guidelines, which we will go through next, but there is some confusion sometimes. Shift to cosmetic practice. Insufficient awareness of the dentist's role in antibiotic resistance, which is one of the reasons we're having this talk today. Impact of underinsurance. So they're worried that some patients will not have the right insurance and have more time to come back to the office for further therapy. Aging population, which echoes what we saw earlier, that most of the antibiotic prescribing is in patients above the age of 40, and more dental registrants per capita. So what are the guidelines and what do they tell us about when to use antibiotics in the dental setting? Prophylactic prescribing of antibiotics is required in patients with pre-existing disease, so patients that already have a criteria that requires, and we're going to talk about this criteria, in addition to procedures that carry a high risk of infection. And it's specifically a high risk, the procedures are manipulation of gingival tissue, manipulation of periapical region of the teeth, and perforation of the oral mucosa. That means that if a patient has a pre-existing disease, such as valvular heart disease, and they come in for just cleaning their teeth, which does not entail any of these procedures of manipulation of gingival tissue or the others, that means that this patient does not need prophylaxis. What's interesting, though, is that the UK NICE guidelines of 2015 recommends no prophylaxis at all in in any indication. No prophylaxis at all. However, the American, Australian, and European guidelines recommend prophylaxis in specific. If you go back to this study, we looked at patients with pre-existing diseases. So what are the diseases? Prosthetic cardiac valves, including transcatheter implanted prosthesis, prosthetic material used for cardiac valve repair, previous infective endocarditis, unrepaired cyanotic congenital heart disease, or repaired congenital heart disease with residual shunt or valvular regurg, cardiac transplant with valve regurg due to structurally abnormal valve. So for the audience today, I know not all of you are in the dental practice, but the point here is that there are specific indications that require antibiotic prophylaxis, and not everybody should receive them. As you can see, they're quite complicated cardiac conditions, and they do not include hip or knee prosthesis, for example. Inappropriate indications for prophylaxis include just giving antibiotics post-op, simple procedures or uncomplicated surgical removal of teeth, total joint implants, as I mentioned, cardiac pacemakers, penile breast intraocular implants or prosthetic grafts, and patients on oral bisphosphonates. So this is the list of patients that do not require antibiotics pre-op. So even if you have deep gingival manipulation, you don't need an antibiotic here. What about what antibiotic regimen you're supposed to use in this case? In prophylaxis, the recommendation is to give within 30 to 60 minutes before the procedure, before the actual skin incision or gingival tissue incision, is amoxicillin, or if they're unable to take oral medications, to give IV ampicillin or cefazolin or ceftriaxone. If the patient is allergic to penicillins, to give cephalexin, clindamycin, or azithromycin. If they're allergic and unable to take oral medications, then you can consider a cephalosporin if the allergy is not severe, or clindamycin. But if you note here, there is no augmentin or amoxicillin clavulanic acid used here. The recommendation for prophylaxis is mostly amoxicillin 2 grams. So it's a very easy dose to remember. So that now that we've discussed surgical or prophylaxis for dental procedures, when should a dentist consider, or when should, as you as patients as well, consider that your dentist may give you an antibiotic? Signs of spreading infection is basically the main idea. You have to make sure that there is an infection first. So the patient feels unwell generally, and it may be associated with a dental infection, a temperature, a fever, tachycardia of more than 100, or marked regional lymphadenitis. And what are possible inappropriate indications for antibiotics in dental disease? Management of pain with irreversible pulpitis, chronic dentoalveolar infections, unless there is a clear evidence of large local spread, acute pericoronitis, if local measures are possible. So if you can manage it locally, then great. You don't need an antibiotic. Dry socket, if local measures are possible. And of course, uncomplicated sinusitis. You don't need to give antibiotics to treat uncomplicated sinusitis if the patient is going for a dental procedure, or in general, actually, you don't really need to treat uncomplicated sinusitis. And what antibiotic regimens would be used? Amoxicillin, as you could use in prophylaxis, phenoxymethylpenicillin 4 times a day. A second alternative or second choice is metronidazole, or clarithromycin. So you see, there is no real good reason to use metronidazole consistently in dental infections. So, and the first choice is usually amoxicillin. Some notes on this. Phenoxymethylpenicillin, for example, should be taken on an empty stomach because of absorption issues. Metronidazole is for allergies and predominantly for anaerobic infections if the dentist deems the infection to truly be anaerobic with a deep abscess. Clarithromycin can cause nausea and vomiting, and it's more with erythro and azithro. So this is, one thing to look out for and counsel your patient on it. And it's really, really important to note that the general duration here is 2 to 5 days, depending on the regimen. So a maximum of 5 days, and 7 days is way too much in most situations. The last thing that I'll mention here is that clindamycin, amoxicillin clavulanic acid, and cephalosporins are really rarely warranted, so you don't really need them. The other important thing is, if you are now having a patient in your clinic and you're not 100% sure if you need an antibiotic or not, but you may need it based on what we've discussed, you may give the antibiotic for 2 to 3 days and have a follow-up. And if the swelling looks as though it's improving and the temperature is returning to normal, you may consider stopping antibiotics depending on the situation as a dentist, as a prescriber. But from the patient perspective, of course, we request that all patients take the antibiotics as suggested by their physicians, unless they have a concern in which they can speak with their physician about it. So in summary, there are indications for prescribing antibiotics in dental practice as an adjunct for the surgical treatment of an acute or chronic infection. So the main treatment for infections is surgical, and you get help basically by using antibiotics. To treat infective diseases such as necrotizing ulcerative gingivitis, definitive treatment may be delayed due to referral to specialists. So you know that the patient needs to go from one city to another to see the specialist, or COVID is there and you can't, we have a lot of COVID cases and there's a quarantine in your area and you can't have the patient come visit you within the next couple of days. Or if the drainage requires sedation or general anesthesia. And it's rarely, really used for prophylaxis. So now for you as healthcare workers in general, what do you expect, or if you are in the dental setting, what do you expect to do, or what do you expect your dental practice to be doing? Dentists and dental settings should at least understand their prescribing patterns. So understand their baseline, and by checking aggregate antibiotic use and patterns of use, get rates of infections and resistance in common pathogens if you think that you have this data, and try to spread awareness. So this is a very interesting study that was done at well, it was published at the Saudi Dental Journal that looked at knowledge of antibiotics among dentists in Riyadh private clinics. And they found that they did a quiz basically, and they saw that only 42% of dentists passed the quiz of which is a knowledge assessment quiz, and their knowledge about antibiotic prophylaxis was only 50% knew how the right practices. And so this study suggests that there really needs to be a focus to be given to pharmacological aspects of prescribing, pertinent medical conditions, and prophylactic use of antibiotics. So the data is there. We just need to find ways to implement improvement projects in these dental clinics. So what kind of improvement projects are there? You can set up your local guidelines for treatment and prophylaxis. And however, even if there are guidelines, it doesn't mean that people will implement and use them. So it's important to educate and try to push to have a discussion with the prescriber about it. You can study or set up an audit and feedback through written behavioral changes, behavioral change messages. So, for example, your prescriber puts in an order for Augmentin as a dentist, and then you educate the team and commit to giving feedback to the physician, to the prescriber, if there is Augmentin, because your policy suggests amoxicillin, for example. And when the dentist is approached, the discussion would be, you know, dear dentist, you've prescribed Augmentin, but our policy says we need to use amoxicillin. Is there any reason for you to use Augmentin? And from our practice here at the National Guard, we haven't done this with the dental setting yet, but in general, prescribers are happy to have this kind of feedback, depending on the way that you communicate it with them, because this is also a way that you look after their patient. So this is in general perceived well. I know you may think otherwise, but with time, when people trust you and people have a good interaction with you, or that's what you should try to seek. And if they have a different opinion, you need to be able to have a clear communication and a discussion. Another example of interventions is suggesting to take aspirate samples when possible, and allowing this to be an option. So if you make the process really difficult for dentists to take samples and send it to the microbiology lab, and they're going to get the results after 2 weeks, then it's just going to be difficult to implement this. And educate about the just-in-case prescribing, which is prescribing from the physician's perspective, just in case there is an infection. This is really something we really need to avoid in all situations. No one prescribes insulin just in case the patient is diabetic, and this is how we need to perceive antibiotics. There's a lot of really nice educational material online about antibiotics in the dental setting, published by the NHS. And there's a lot of other information as well, but this is just some of it. So it's really nice. It's information targeting the dentist as well as the patient. So if you see here in red, the recommendation is call your dentist after. If you see the dentist and you're worried, call the dentist if you develop a fever, if you have redness or swelling of your face, jaw, or neck, if you're unable to open your mouth, if you have severe pain uncontrolled by pain medicine, and if you're having difficulty swallowing. This is an example of our Antibiotic Awareness Week in 2017, where we had the dental team come in. And so what we used to do is we would have booths. This is pre-COVID, as you can see. We would have booths set up by different departments. The medicine team would have a booth, and they would discuss medical issues such as pneumonia, UTI. Nursing would have usually a lovely, beautiful booth. Quality, pharmacy, microbiology, and that year and the subsequent years after that, we had representatives from the dental setting as well. And you know, one really important thing about these activities, and this year we had a really nice event as well, is that not only do the dentists themselves create the material, but when you're creating material for anything, you also learn a lot. So this is a really good way to involve people, to get them excited about the activities and the changes in practice. The other thing is, of course, prescriber education. So you have to have clear guidelines and recommendations in a very easy to access format. You can see here on the left-hand side, there's an algorithm which clearly suggests when to use antibiotics. And on the right-hand side, there is a dental prescribing app created by the Scottish Dental Association with the NHS. So these are really nice resources. And so the take-home message for today's talk is that antibiotic prescribing in the dental setting is not really discussed very often, but it's a very important part. It's a low-hanging fruit that we can easily address. We may not have a problem, but we won't know till we check, till we look. So the first step is to assess what's happening in your facility, in your clinic, and then you can go from there. Overprescribing can lead to serious adverse outcomes, side effects, resistance, and C. diff, of course, in addition to increasing cost and discomfort to the patients. Something as simple as change in taste or antibiotic-associated diarrhea can be really make your patient miserable. Stewardship is a group effort, so you can start with your facility and slowly build up to including physicians, pharmacists, nurses, quality specialists into your small stewardship group within your dental practice, and try to find ways to be creative and start today. So if you don't have a team to start orchestrating a large process improvement, you can start by doing sitting together with your dentist, having a discussion, creating some educational material for patients that are just printing them out by of all the resources that are available online, and go from there. So these are some of my references. I'll leave the floor open now for questions. I will be checking the questions now.